Kia ora koutou katoa. Welcome to our lunchtime webinar series on research topics and of interest to the healthcare community. And I'm very pleased today to welcome Wendy English. Wendy's going to talk on health communication research and reality in the context of serious illness. And I heard Wendy talk on this. The Postgrad Centre in Christchurch, University of Otago, had a research seminar morning, and I heard Wendy speak then, and I was very impressed. I'm looking forward to this. Wendy is a research advisor and registered nurse and specialist palliative care at Nurse Ward in Ototahi, Christchurch. Her fascination with rapport and connecting with patients and their whānau families began with a master's degree at the University of Canterbury and led to a PhD through the University of Auckland. She's an honorary research fellow at the University of Canterbury and at the University of Auckland, and a member of the Tiarai End of Life Research Group in the Auckland School of Nursing. And as a health communication researcher, her interests include interpersonal communication, telehealth and technology and community health care, palliative care, equity, and critical reflective practice. Kia ora, welcome Wendy, and we look forward to hearing from you over the next little while. Over to you. Thank you.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Wendy English toko ingoa, ko rangahau toko mahi. So I'm a research advisor here at in Ototahi, which means I get to support clinicians with research, but also do our own research here. So it's a pretty exciting role, and I'm really grateful. And I also have a clinical day in the specialist palliative care team, and as a nurse, which really helps me integrate research and practice. And that's sort of what I wanted to talk about today. And thanks to Lorraine for inviting me. I'm really grateful to be here. So my topic today is called The Moments We Meet. That's actually comes from my master's title, and it's stayed resonant with me. And now I've learned more about the moments that we meet. And today we're going to talk about health communication research and then the reality of the lived experience in the context of serious illness. So our conversation today, just for these few minutes we're together, I thought I would just give you a brief overview of the PhD, just to inspire you to do one, and how relating the rapport from my research has sort of intersected with the fundamentals of care model. And then I'm going to give you a couple of real life rapport examples, one from research and one from clinical practice. So as I've mentioned mentioned in my introduction, I'm a health communications researcher. I do a whole lot of other research, but this is the core of what I love and what excites me to be doing this. And I've been doing it for the last 10 years as a topic. I think it was looking at how people were interacting with patients and families with serious illness, and how the power of our words and our way of communicating and how it impacted on people's health and well-being. And I'm really passionate about our workforce developing communication skills and really honing this idea of being present and how to use our presence. It's particularly in telehealth or in this sort of virtual forum, how you can kind of still connect with people. So my research mahi over the last decade has also been in regard to kanohi, ki te kanohi, face-to-face, but also with telehealth. So title of my PhD was Experiences of Rapport in Telehealth Encounters from the Perspective of Patient, Family and Health Professionals in Palliative Care. And I did it through the School of Nursing in graduated in 2023. It was a 3-phase study, and I used a predominantly interpretive descriptive methodology, which from Sally Thorne, 2016. And there were patient and whānau interviews. There were 28 of them, and there was health professional focus groups and interviews, and there were 30 people involved in that. And those interviews and focus groups took place in 4 places throughout the country. There was Southland and Canterbury, Otatahi, and then there was Northland and Waikato. So that was pretty interesting, looking at the rural and city mix, the metro mix, and the different populations across the country. So when I analysed all that data, I put the findings across a theory of human relatedness, which was a pretty simple theory, but it came from a humanistic nursing pedigree, if you like, from Hegarty et al. In 1993. That theory was published. So for the sake of this talk today, I'm going to just present 2 findings from my research. And interesting, when you start to look at the topic, I went to look for a definition of what rapport was, because obviously that was a key concept in the study. And there weren't any definitions, and there was no consistency. So I did a thorough literature search on that. I ended up creating a definition for rapport based on what the patients and families told me from the interviews. And it looks like this, which is 4 parts to it. So, and you need all 4 parts for it to be considered to be rapport. So the first part was, it was a conceived connection between patient, family, and health professionals. So everyone perceived that it was a rapport type relationship and connection, and that the interaction was experienced as relaxed, positive, friendly, and based on caring and acceptance. And the particular communication characteristics that everyone commented on, well, not everyone, but most people commented on, was the type of listening and ultimately understanding, and preferably listening to understand rather than listening to speak. And then this is the bit that I think was really interesting, is that all of those things needed to be present to the extent that the interaction fostered confidence and trust for both the patient's family and the health professional. So the health professional needed to be confident and trust that there was rapport going on, as well as the patients and families. So that was quite a profound finding, and it's proven to be quite a useful thing to have a definition of what we mean by rapport. The second thing that, and this is perhaps what Lorraine was referring to about a model that I was presenting in Otago, was this is the findings once I had done the analysis from the focus groups and interviews, and I kind of layered the findings across this model. So the model was originally just the 2 axes. It was the north and south axis, which is involvement through to lack of involvement, and then across the horizontal axis was the going from comfort and well-being to discomfort and a lack of well-being. That was essentially what was there. And then by placing the data that I had found in relation to rapport, I then discovered that rapport only occurs in that golden quadrant where there's a high level of involvement and a high level of comfort. and it creates a sense of well-being. And indeed, it also creates this possibility of a transformational zone or a healing zone. So this is where the good stuff happens, and this is what we should be aiming for. And you can see in the corner of the quadrant there, there's two intersecting shapes there to indicate what the two the meeting of the two, the moments that we meet. And conversely, if we look at the purple quadrant, the disconnectedness, lack of rapport. So this occurs when there's a high level of discomfort and a lack of well-being, and also a lack of involvement. So you can see the two arrows in the center of the purple quadrant there are divergent. They're never going to meet, and they are, sort of like, I called it in my thesis, like shouting across the abyss. It was, quite a damaging and belittling experience for a lot of people. And there was also this sense of it being unethical, like we shouldn't be communicating like this. So the other two quadrants are quite interesting and they haven't really appeared in the literature before. And I think there's areas of further study needed here. Is these what I've labeled pseudo rapport. So they're not rapport, but they're not rapport either. They're sort of in this grey zone. So in the blue quadrant, which I've called cool parallel, so the lines are parallel to each other and they're close and you can get things done. The blue quadrant occurs when there's a high level of involvement, but there's a high level of discomfort from the participants in the interaction. So it would be like having someone who's very proficient at their work, but they're not necessarily relational. So for the patients and families experiencing that, they felt that was, you'd get good information from it, but the information didn't really penetrate in because they didn't feel the connection with the clinician. And then on the red quadrant and the warm parallel, similarly, there's two parallel lines, and it is warmer because there's a sense of comfort and well-being. But there's unfortunately a level of lack of involvement there. So that can be when somebody is very friendly, but and there's a sense of relationship, but there's not a sense of maybe clinical expertise or a sense of the person actually really caring about them in terms of this professional setting they're in. So this model has got kind of like a lot going on here, and we'll come back to it when I look at these examples. But I think essentially a rapport only occurs in that top quadrant. Disconnection is really highly undesirable. And then there's these blue and red zones of pseudo rapport, which are a grey zone for our clients and families. So I've been lucky enough to look at some data from complaints and compliments, and also sort of patient whānau feedback surveys, and I've looked at them through this fundamentals of care model. It's been very interesting, and I know that you're looking at using this model in Southern, which is great, and I think there's some excellent work here. My work fits entirely into that sort of green relationship bubble there. And what I found with the complaints and compliments data that I've been looking at is that when someone bothers to make a complaint, there's usually a total lack of relationship. So there's no trust, focus, anticipation, knowing, or evaluating. And when they bother to make a compliment, there's usually exemplary examples of those things. So that was quite illuminating. And so then when I thought about how does rapport fit into that, and how does my definition of rapport fit into that? It seems really clear that when you're experiencing a positive, friendly, caring, accepting relationship that's characterized by listening and understanding, and that it develops confidence and trust, that is going to enable you to develop trust with patients and focus on the patients and give them undivided attention and to anticipate their needs and, you know, be able to plan, care, and evaluate the quality of the relationship. It was really interesting looking at that data with that idea of if there's no rapport, then the relationship can't be functional, and the care, if we go back to the physical, psychosocial, and relational care, is really difficult to deliver without that. It is essential and not optional to have a relationship, to have rapport with someone. So, there's an example from my research, and it was the same woman in both scenarios. She's a young woman. She was with a family, and it was both of them were telehealth calls and from a health professional. And one of them said very early in the conversation that we're wasting resources on you. That triggered a really painful series of painful reactions for her from past. And she said to me that they labelled me as difficult. She was also a health professional, so she knew that how damning it is to be labelled as difficult. So that was a really disconnecting purple quadrant experience. And then the converse was when she changed providers and had I asked her for a positive example, and she said, wow, her physiology changed when she was talking to me. She was like, oh my goodness, they just rang me to see how I was. She was amazing. She was like caring. I was made to feel part of the team, and ultimately it was all about me. So when we look at that, obviously there's an example there of the purple disconnected and feeling disenfranchised. Her physiology was very emotional, and she was tearful when she was telling me that story, and then literally brightened and became really animated when she was telling me the second story. It had a direct physical effect, and was quite profound to see. So the second example was, this was recently, earlier in the year. This woman who was in her last days, I was given the task of ringing her. So this is again a telehealth call, and she was known to be challenging. And so I started the call, and she, sure enough, started making quite challenging statements, and really, what do you know, and what do you care, kind of comments. So, and I felt like I was being dodging sort of like missiles being thrown at me. Really, it was and it was sort of like a landmine, like dodging landmines and things. And I knew it was a test. So eventually we established rapport by I finally realizing that she didn't want me to be a nurse. She wanted me to be anyone else but a nurse. And I said, well, I'm also a researcher. And she goes, and this is also a wee plug for being a researcher, because see how handy that was. So as a researcher, I said, I'm looking at these topics. And she said, well, I'm a researcher too. I said, well, what are your topics? And she said, I'm looking at the effects of what health professionals' words are on my sense of well-being. And I said, we're looking at the same thing. So she gave me this word, and it's a composite word that she has put together. She wanted me to share it with as many health professionals as I could, because she wants people to know this is not how to communicate. So this is the disconnected purple quadrant, and it's when someone is condescending, patronizing, and demeaning, and a competist to someone who practices this type of communication. And compatistry is the practice of being a compatist. She had thought about this in great detail. This just flowed out of her. And she asked me to tell her who I was going to be talking to and when and how often, and wanted to know that right up until her dying days. So the next, going from this current lot of research, I'm now in this project for important conversations. And this is looking at developing and evaluating an important conversation workshop for nurses, particularly in the community setting, who are caring for people with serious illness. And so it kind of comes from that serious illness conversation work and also from Vital Talk training. So Dr. Lee and Dr. Julia and myself are all Vital Talk trained. We've got UC Ethics approved, and we've done the initial survey, and we're just analysing the results before we start the workshop. And the initial results show what's challenging in terms of communication tasks and what's important in regard to the communication tasks that people are undertaking in this context. And it's proving to be really interesting. So maybe I'll come back and tell you about that another day. So part of my interest is critical reflection. I'm really interested in the idea of us having an interaction and then really thinking about what happened and what can I do better. What else could I have said? What's another way I could have said it? Those kinds of things. So my question is, if you don't have rapport with someone, is it nursing? And I think it's that model, again, going back to the fundamentals of care and thinking about the relationship. If you don't have the relationship and you don't have the rapport with someone, that level of connection where you've got confidence and trust, then how is it possible to do the nursing? You know, so I guess it's like, I think it is that important, that it is that essential. And is how you're communicating the kind of communication and care you and your whānau would want to receive. So those are my little kind of prompts to you to have we think about. And that's the end of my talk. Tēnā koutou, tēnā koutou, tēnā koutou katoa, ngā mihi nui.
Thank you very much, Wendy. Does anybody have any questions or comments to make for Wendy? We could just wait and see if anything comes in the chat, but I've got a couple of things, if I may.
Yes.
I'd really liked your comment, listening to understand rather than listening to speak. I really like that, a different kind of listening, and practicing that kind of listening. And also your model, while I was looking at it with the zones, it made me think a bit about the therapeutic model, the therapeutic zones of Nursing Council. Remember that one within the professional boundaries, that you can be overly involved or not involved enough, and in the middle is kind of it's not as precise as yours, but it kind of reminded me of that model. And I guess my last thought was, when you were talking before about, is it nursing if it's not relational? I'll come back to that because we've got a question that's more important. And it's from James Cayley, and he said, are mental health nurses part of the communication workshop research?
Great question. So what we're doing is piloting, because it's research, we're just testing out this idea and this way of teaching, and so getting feedback and evaluating that. So then I think we'll take it out into the community more widely. And currently it's only in Otatahi and, you know, with this palliative care and district nursing and practice nursing. So, and aged care, but not mental health. And I love that suggestion. And I think, that would be a really good place to take it.
Thanks, Wendy. There's another question or comment. Question and comment. How do you work with improving these skills in different cultures of nurses? For example, some are task focused and it's not part of their culture to make small talk like Kiwis do to establish a sense of rapport.
It's a really good, great question. So I think there's two things, isn't there? It's like, so being a task-focused nurse, it's like it's really important to go, yes, that's great. You're going to get a better result for you're doing your tasks if you can also do this. So, and having it modeled and showing, just because it can be tiny little comments, it can be just even non-verbals and paraverbals, it can be how the tone of your voice, and it can be also just a smile. So it doesn't have to be a lot of chat. It doesn't have to be, challenging, too much behavior challenge. It can be small incremental changes that make a big difference. And just also having a sense of taking time. So people say, oh, but all this rapport nonsense takes so much time. Well, it actually saves so much time by having this wonderful mutually beneficial interaction with your patient and family who are going to need you less because they're feeling better. But I think for nurses who come from another country who have maybe English as a second language, I would be strongly just encouraging them with non-verbals.
Sorry, strongly encouraging them to
use their non-verbal communication, just like a touch, a smile. They don't have to, be marvelous at chit chat, because chit chat isn't it? It's not. It's asking one question in a way that people go, oh, there she is. She's there for me.
And somebody has said that's a great answer. Thank you, Wendy. That question kind of related a little bit to mine that I was going to ask, perhaps not so much, but I do understand from other cultures, English is a second language, different ways of being relational and interacting and touch, all of that being quite different perhaps from another country, coming from another country, was the nurses who might say, I haven't got time to be relational. I mean, we're flat out, we're 2 staff down, total realistic scenario. I can't build up rapport with people when I'm running around, and what would you say to that person?
Well, obviously I've been that person, and so it's like I would always, like, I'm thinking particularly on a shift where you might be short-staffed and you've got really sick patients, and some of whom might be dying and some of whom might be ambulatory. So it's like I would go to each of my patients and say, this is how it is today, and this is how I'd like us to work, and how does that fit with you? Establish that and just be really honest about how short-staffed it is, but not make it their problem. I still want to hear from you, but it may be that I'm going to take longer. Just set realistic expectations and just talk to them as partners.
Yeah, that sounds great. Because often patients are very understanding, aren't they? They can see what's going on, and
I don't want people not to ask me for something, but just like let's work together.
Yeah. Because if nothing is said, people are left to be guessing and wondering.
And you go in hostile, right? It's like, what do you want? And it's like, I've got to go. And you do a half-baked job and, all of that. Whereas I found that's a really successful technique in terms of just people going, okay, well, almost like actually, rather than waiting, can you do this for me now? And then I think I'll be fine for the next hour or so,
Yeah.
Yeah.
It's respectful too, isn't it? Great. Does anybody else have any questions or comments for Wendy just before we finish up? It sounds like the course that you run, the workshop, there'd be a lot of interest in that. Yeah. Do you run that through Nurse Maud?
Well, we're just piloting it, and it will be, I think, run through Nelson. We haven't quite got to that part. We want to see how successful it is first. So there will be probably around 20 people on that first pilot, and we'll do a skills, evaluation and post to see if it's changed and
Right.
giving people confidence and skills. So, and the idea basically is to not be afraid of asking those questions when someone's seriously ill. And it's like things like, so what's your understanding of, where you're at the moment from what doctors have said or what the scans were, and just, having a conversation with people.
Yeah. We have one last question.
Oh, yes.
I'll make it. Wendy, there's another very good question from James. How do we champion the organisation to prioritise caring about caring?
And the organisation is this large Te Whatu Ora organisation. Is that what?
I guess it's ours. I think, or any organisation you could say, really.
Yeah,
any health organisation you work for, I think.
So I think
on James, but yeah.
So James, I think it's a great question, and I love how you're thinking. I always go back to the values of the organisation. So I say, okay, so it's like if manaakitanga is important to us, how do we demonstrate manaakitanga? And because obviously that is me coming into your space as a patient and family. And so it's like, if these are the values that the organisation are purporting to hold, then I would challenge I need to be able to, this is what I need to be able to make that happen. So for manaakitanga, it's like, that we've got a space, that we've got food, we've got time, and we've got, we can offer hospitality as well as, as part of our care. So if that's what's on the badge, then I'd be asking management to back it.
Good answer. So finding out what our values are.
And call them out.
Okay. So we're Health New Zealand at the moment. Yeah. Southern District Health Board had a lovely set of values, and the first one was manaakitanga. I don't think they're in the past, though. I think they absolutely still exist. And so good answer. Where are your values in this?
I think.
Oh, hang on. I think there's yet another one.
There's values.
Another great answer.
I've got a fan.
And James said thank you.
Oh, pleasure, James. I have got definitely used that as a technique. It's like, if this is what our public facing values are, then this is what we need to be able to achieve those values. How does it look in our workplace? What do we need to make that work?
Yep. Well, on that note, we might leave it there, Wendy. We could listen to you for a lot longer, so may well have you back. Be really interesting to hear how the workshop goes.
I'd love to talk to you about that. That'll be great. Yes, and we can invite.
Pardon?
And we can invite James to attend, can't we?
Yes. Oh, ngā mihi nui, and nice to see you again, and we will keep in touch. Kia ora.
Thank you so much. Kia ora.